Let's talk about the next drug class, the SGLT2 inhibitors. These are the gliflozins, so they all end in gliflozin. And it's kind of a nice name because you can remind yourself, keep the glucose flowing, because that's exactly what they do. They keep the glucose flowing. So their target is the kidney. And these are drugs like canagliflozin, empagliflozin, dapagliflozin, ertugliflozin. And so if you are here in the kidney, in the proximal tubule, what we're going to find here is a transporter, which is the sodium glucose transporter, taking up glucose and also sodium. And that's what this name stands for, sodium glucose transporter 2. And then the glucose gets into the blood via GLUT2. So that's here GLUT2 on the basolateral side. And what these S-GLUT inhibitors do is they block this transporter, the SGLT2. So these are our SGLT2 inhibitors. This is just their mechanism of action in writing. When you block 90% of the glucose that usually gets reabsorbed via this SGLT2, well, then you're going to lose all the glucose. You're going to have increased glucose secretion. That's also causing osmotic diuresis. So this drug class can be also put into the category of diuretics. So let's talk about the therapeutic effects of this drug class. So they lower A1C less than 1%, making them low efficacy drugs. They also don't lead to any hypoglycemia, so that's a good thing. And they also lead to weight loss. And you can think about mechanistically just like you lose glucose, so you pee out calories. So that's this mechanism. And then they also have been shown to have beneficial effects on the cardiovascular system and on the kidneys. It's fairly well understood what they do. We know that because of the blocking of this S-GLUT transporter, there's going to be more sodium delivered to the macula densa. And if you have more sodium delivered there, what's going to happen? You get tubular-glomerular feedback. That's going to lead to a constriction of the afferent arteriole. So there's going to be less blood flow, and you're going to reduce intraglomerular pressure, which is going to slow progression of kidney disease over time, helping also to decrease proteinuria. And then also because you're going to have more sodium delivery to the macula densa, and through the tubular glomerular feedback, these drugs also increase adenosine, which is going to inhibit renin, so you're going to get a less activation of the renin-angiotensin-aldosterone system, which is a proven benefit for the cardiovascular system. Let's talk about the adverse effects of the S-GLUT inhibitors. So one very common adverse effects are genital infections, and this is very predictable because you're going to inhibit glucose reabsorption, so there's going to be more glucose in your filtrate in the urine. So I mean, who wants to be around glucose, yeast, bacteria? That's their best habitat. So you're going to promote urinary tract infection, any yeast infections. And then there's also something rare but can be dangerous. There's something called Fournier's gangrene. That's a flesh-eating gangrene, flesh-eating infection in the genital and groin area, just promoted by bacterial growth. And this is due to, again, glucose in the urine. Then patients can have hypotension, should make sense because, I mean, these are diuretics. They cause osmotic diuresis, so blood pressure is going to drop a bit. And then they can also lead to acute kidney injury. And that may seem a bit contradictory because I just told you these drugs have renal benefits. And where do these renal benefits come from? Well, we said we're going to have more sodium delivery to the macula densa, and through the tubular glomerular feedback, we're going to have an effect of more constriction of the afferent arteriole. And that obviously is good on the long run, but initially it's going to drop our glomerular filtration rate. GFR is going to drop, and that can potentially lead to an acute kidney injury if you just have very little GFR left. And then we have another rare but potentially fatal effect. We can develop diabetic ketoacidosis and euglycemic, which means our glucose level are going to be normal because we're going to lose glucose. So usually for DKA, you have high glucose level. In that case, they're going to be normal, but you're going to have ketoacidosis. And this comes from SGLT inhibitors also leading to increased glucagon production, leading to fatty acid breakdown and ketone production. So we're going to make these ketones, which can get us into a ketoacidosis. So the risk to develop diabetic ketoacidosis is higher if you are on a specific, let's say, diet, like a high ketone diet, or a type 1 diabetic patient is also on a higher risk. And these drugs are sometimes used off-label also in type 1 patients with type 1 diabetes. So that increases the risk for diabetic ketoacidosis.